Tonight, the final report in our three-part series, Desperate Measures, on the challenges terminally ill patients and their families face when treatment options run out and the only thing left to try is experimental drugs. Among the challenges, a lack of uniform guidelines or laws that determine which patients can get access to those new and unproven medications. Meg Tirrell has the story.
Compassionate use is a last resort for the sickest of patients, like Natalie Trawler, a 15-year-old who's been battling an aggressive cancer for 2 years.
When we found this new promising medicine, PD-1, we definitely wanted to participate in the trial, and we asked for compassionate use, but they denied it.
Companies can use compassionate use to give patients access to experimental drugs outside of clinical trials.
There are three parties in these expanded access programs: the patient and their doctor, the FDA, and the pharmaceutical companies, and all three have to be in agreement if the drug gets to the patient.
It is not a simple path, and a swell of public outcries is putting pressure on the system to change. One issue, a lack of guiding industry principles. Tony Plahoros consults for drug makers, fielding requests for compassionate use.
Is there an individual sort of arbitration process that can be put in place? Or should there be a universal sort of set of principles that regulators and companies might agree to that won't be compromised in the face of a strong public pressure campaign?
Another initiative is Right to Try, a law that's been passed in 3 states and is being considered in several others.
The Right to Try is about giving terminally ill patients the right to fight to save their own lives.
The Goldwater Institute designed the laws, which remove the need for the FDA to sign off on compassionate use requests.
As soon as a doctor tells the patient that there is a promising drug for you, the patient can then go out right away to the company and seek that approval. And that's going to cut down on the time that patients have to wait enormously.
The FDA counters that the laws are focused on the wrong place. Of 977 applications for compassionate use that made it to the FDA last year, all but 3 were granted.
The potential problem here is the pharmaceutical firm has to agree to give the drug.
Bioethicist Art Kaplan puts Right to Try a different way.
But they're right to beg laws.
And he says other changes are needed, including creating funds for patients to pay for treatment and travel. And in addition to a push for getting medicines to market faster, Kaplan says regulators could make other changes to facilitate compassionate use.
The FDA probably could be a little more flexible, probably need to have some reform there to say if people die taking experimental drugs, we won't hold that against the drug in terms of the approval process. We want to know, but we're not going to penalize you.
The focus on compassionate use has risen to a federal level, with a push to gain more data on how the system's working. Any changes, though, may not come soon enough for patients like 15-year-old Natalie Trawler and the many others battling diseases with no good options.
Every day that we don't do something or don't try to fight the cancer, like that's another day that the cancer can grow and get worse. So we always feel that in the back of our minds, that pressure that there is a time limit.
Meg Tirrell is with us now. Meg, you mentioned that the federal government is becoming more interested in compassionate use. What, if any, kind of changes are brewing?
There's really a focus on gathering more data. There aren't good numbers on how many of these requests get made to companies and how many are denied. The figures we showed were just from the FDA, and that means they'd already gotten through the companies. And then the FDA had a chance to review them, and they only rejected 3 at that point.
The FDA only rejected 3.
The FDA did, but we don't know how many go through companies. And so there's a push to understand that better, and also some legislation potentially brewing that would ask the GAO to take a look at how well compassionate use is working.
The momentum is really kind of building right now, but how long has the system been in place, really?
So it actually started in the 80s. The compassionate use system was put into place in 1987. This came into place around HIV/AIDS, and then was adopted again by breast cancer activists in the 90s with a drug called Herceptin. So this has been around for a long time, and there have been reforms made to the system. But it's interesting because now there really does seem to be a momentum building for the system to change, and it's through things like social media. It's because companies are pursuing rare and unmet need diseases, and so people are at a much bigger need for these drugs.
we're a little short on time, but I wonder whether some companies are known as more compassionate than others. It may not have to do with their compassionateness per se, but with where their drugs happen to be working.
No, it's really interesting that you bring that up, because in this story we focused on 3 companies that Natalie was asking for drugs from. One of them was Genentech, and actually in the 90s they were involved with that drug Herceptin, and they did figure out a compassionate use program, but not until they'd been pressured strongly by these breast cancer activists. So it often takes a lot of patient voice and power.
All right, Meg, thank you for your reporting. A wonderful series. We appreciate it very much.
Keep us posted on Natalie's progress.
And to read more about Meg's series on compassionate use, head to our website, nbr.com.